All right, so looking at how to open the airway. So there's two methods that we can do this with, and that is the head tilt chin lift and the jaw thrust maneuver. So one of the biggest concerns with an airway that is blocked is going to be the tongue itself. And so there, again, is two ways that we can move that. The first being the head tilt chin lift. Now this needs to be only used in patients who do not have the potential for spinal cord injury, as it is going to remove that head from a neutral or inline position. So essentially, you're doing exactly what the name is describing. You're putting your one hand on the forehead, one hand under the chin, head tilt chin lift, kind of lifting it up in a sniffing position as if the nose was pointed higher up into the air, taking a sniff. All right, that's where it gets its name. So head tilt chin lift. Now the other one is the jaw thrust maneuver, and again, this one is used for patients who have the potential for spinal injury, and so you can keep the head in a neutral or inline position. You're not moving the spine at all with this. This is a little bit more uncomfortable, and so the patient would really need to be unresponsive or close to it for you to be able to utilize this effectively. In most cases, they would be if that was a concern for the airway. But you're literally lifting up underneath that jaw, so putting those fingers underneath the jaw and pushing down and lifting up at the same time. And so this one is a little bit more intense, again, can cause some pain if the patient is not completely unresponsive, and you've got to hold it. So whereas the other one you can just reposition and then move on, this has got to be held the entire time, so it can become a little bit more intensive for you as the provider. Now, looking at suctioning, a way to clear the airway for vomit, blood secretions, things like that. You have several different types of suctioning. You have portable, hand-operated, and fixed equipment. So the one that's going to be fixed in the ambulance is what you see there in the middle, and that's attached to like your main suction line and attached to the wall of the truck, have everything there. The hand operated is going to be what you see in the first picture. That's going to be least likely to be used, least effective, because you have to squeeze that to actually create the suction, and it can be kind of doesn't work as well. And then the portable is the same as the fixed equipment setup, but again, it has a battery so that you can take it out into the field with you, and that's probably one of the most common. Now, you'll talk about all of the different pieces of the suction equipment when you're here on campus, but just considering the use of a rigid or Yonkers suction catheter, which is what you see them holding in that middle and last picture. There are also flexible or soft suction catheters that can be used to suction down tubes or in the patient's nose, or for a very small child if it's a small airway. And so it should have that plastic tubing that's going to keep everything safe and go into that sterile container. The suction needs to be at minimum at 300, and so when you see that suction, you should be able to turn it up or turn it down on the adjustable controls. Minimum of 300 to be adequate. Now, looking at some techniques here, you would use a cross finger technique, ideally to open up the mouth. And so you can read more about that in the textbook or in the original PowerPoint for this slideshow. But then once you've opened the mouth, you're going to suction for a maximum of 15 seconds for adults, 10 seconds for children, and 5 seconds for infants. All right, because as we're suctioning, we're actually removing oxygen, and the patient could become hypoxic. So that's definitely a concern, and we want to limit the time that we are suctioning. Now, we could reoxygenate the patient for about 2 minutes and then reattempt to suction. But what do you do if it's continuous? All right, so much vomit, so much blood that you need continuous suctioning. All right, the best method is going to be to have the patient on their side if you can, so log roll them, or if there's a concern for spinal injury, you can secure them on the backboard and then tilt the entire backboard over onto its left side. And here you could just allow some of that blood and vomit to drain and help clear the mouth with a gloved finger. So that might be, if this is continuous, the need for continuous suctioning is there because we don't want to cause the patient to become hypoxic. Now let's talk about some basic airway adjuncts. We've got OPAs and NPAs. So the OPA, or the oropharyngeal airway, that's actually going to go into the mouth and help to keep the tongue in place to prevent airway obstruction. Now, this is one of the skills that you'll be learning when you're here on campus, but the way that you measure this is from the corner of the earlobe to the corner of the mouth. All right, and so that's how you choose the adequate size for your patient. Now, to use this, the patient cannot have a gag reflex. So if you go to insert it, or the patient is still conscious enough to have a gag reflex, you would need to choose something else. This would not be a good choice. Now, you can use this once it's in place. You can administer ventilations with the bag valve mask. Or the BVM, and so then you would ventilate that. And we'll kind of talk about some potential complications of that positive pressure ventilation with the BVM in just a second. So this is the NPA, or the nasopharyngeal airway. This can be used in a patient that has still a gag reflex, but that cannot maintain their airway. They need some assistance, maybe need some ventilation, but they still have that gag reflex intact. So you would choose the correct size for this patient by measuring from the tip of the nose to the corner of the earlobe. And then when we go to insert this, you want it to go with the curve of the face. But the way to insert it is going to be with the bevel towards the septum. And so if you see this end that's kind of slanted, that's called the beveled end. And so you want the bevel to be towards the septum. And so if you were going to put this into the right nostril and you start with the bevel facing the septum, all you need to do is lubricate and insert. You don't have to do any type of twisting. It's going to naturally go with the curve of the face. If you insert this into the left nostril, you want to start with the bevel towards the septum. And then as you insert and you meet resistance, you're going to twist that. And so as you turn, it should slowly go in, and again, with the curve of the face. But start with the bevel towards the septum. So again, this can be used for patients who are semi-conscious or unconscious that have an intact gag reflex, or patients who will not tolerate an OPA. We should not use this for patients who have a severe head injury or have any type of facial fractures, where that could be a concern as far as bleeding or potential movement of those broken bones. So we want to make sure that we are very cautious with that. But otherwise, this is a really good option. You can use both the OPA and NPA together, so you could have both in place. It's totally provider dependent. Now, when you put one of these basic airway adjuncts in place, it might be that you can work in an entire cardiac arrest, or whatever you're doing with just this in place. But if for some reason this is not adequate, we would want to move on to something else, like an advanced airway, which we'll be talking about in the next PowerPoint that I created for you guys. So the biggest question is to ask, whether you're working a cardiac arrest or whether it's just that you're delivering rescue breaths, is, am I getting good compliance or am I meeting resistance? Okay, two very important pieces of information to keep in mind. Am I getting good compliance or am I meeting resistance? And if I say, no, you're not getting good compliance or you're getting resistance, then you would want to do something else. Now, the simplest thing, most basic thing you can do is readjust the airway. So if you have one of these in place and you meet resistance, now you could readjust the airway with a head tilt chin lift or a jaw thrust maneuver. But if that still didn't work, if that still did not resolve the issue, then we would need to go ahead and move on and progress and choose something else. Now let's talk about some oxygen delivery devices. We briefly talked about this with pharmacology as far as what devices are out there and how much oxygen can be delivered. But let's talk about oxygen tanks for a second. Most medical oxygen tanks are green in color, and they usually have a label on the outside. Now these tanks might get kind of old. They're usually recycled. You can have them refilled and refurbished. So they might not always have a label, but you definitely want to look for it if it does. Now, oxygen can potentially be dangerous. It doesn't burn or explode on its own, but it speeds up the combustion process. So if it is exposed to any type of fire or flame, it can make the situation a lot worse. So we want to make sure that we are practicing safety here and also never leaving the oxygen cylinder unattended or unstrapped. You can see this is located inside of an oxygen compartment, usually behind the driver compartment of an ambulance, where it's strapped in and secured. It's not going to become a missile or any type of launch device and pose a danger to us. With the smaller tanks, those would be secured underneath the bench seat or in oxygen bags secured to the stretcher or in a side of a cabinet secured, but we want to make sure that they're not just rattling around. Now, thinking about some potential dangers of oxygen, we've briefly talked about what the hypoxic drive means and how we don't want to knock that out for patients that operate with that hypoxic drive with COPD. So yes, there is such a thing as oxygen toxicity. Not every patient needs a high concentration of oxygen. So if the patient is having difficulty breathing, we don't want to withhold any oxygen, but we also want to be cautious about how much oxygen we're giving and for how long a period of time. So we don't want to give high flow oxygen where it's not needed. We don't want to give it prolonged when it's not needed. We really want to monitor that patient and ideally keep that SpO2 over 94%. But remember, we're treating the patient and not just the monitor. So if the patient's not having any signs of difficulty breathing and they're below 94%, then justify that in your documentation as to why you didn't provide that treatment. All right, make sure you treat the patient and not just the monitor. So looking at some oxygen delivery devices, this is the non-rebreather mask, which has a reservoir system on it, and you administer 10 to 15 liters of oxygen through this, and you'll see that process of how to set this up whenever we're on campus working on oxygen administration skills, but this is for high flow oxygen. You want to keep this to whatever setting is going to keep the bags 2/3 of the way inflated. So when a patient inhales from that reservoir bag, it should not deflate more than 1/3 of the bag. So if that's 10 liters, 12 liters, if it is 15 liters, whatever it is, to keep that inflated as much as possible. Now, the nasal cannula is going to deliver a little bit less oxygen. Generally, 1 to 6 liters is what you would choose. Now, there is 21% oxygen in the inspired air around you all the time. And so administering 1 liter of oxygen would bump that up just slightly to 24%. So the patient's going to be breathing through their nose for us to administer this. And again, we could consider humidification for longer transports, or patients who are on oxygen all the time at home. Generally, they will have some humidified water attached to this to kind of moisten the airway passages and not making it so drying or irritating. This is a tracheostomy mask, which is a very specific type of mask, and not all services will carry them. If the patient does have a tracheostomy in place or a stoma, then we want to make sure that we are providing oxygen over that or ventilating through that, because they don't use anything above that. Once they have that stoma or that area to the outside world going directly to the trachea, they don't use their mouth and nose to breathe. So using a non-rebreather or a nasal cannula would really be ineffective for these patients. So just make sure that if you do not have the appropriate or proper mask for this, you can improvise. You see right here, they have pretty much just a non-rebreather placed over that stoma or tracheostomy tube, delivering oxygen through it. So just make do with what you have. And then this is going to be our BVM. And so the BVM used to ventilate patients in the field. And so we want to make sure that we're choosing an appropriate sized bag for the patient and an appropriate sized mask. And so you can hook this up to oxygen. And as you see here in the picture, and when it's hooked to 15 liters of oxygen and that reservoir bag is filled, that's the most oxygen that you can deliver to a patient. You're delivering around 100% pure oxygen right to the patient. So we're going to talk a little bit more about rescue breaths and why bag valve mask ventilation is important in the next piece of the video.